Before we start today's episode, I would like to quickly read you our podcast disclaimer. The content in this podcast is for general reference and educational purposes only. It is not meant to be complete or exhaustive or to be applicable to any specific individual's medical condition. No information provided in this podcast constitutes medical advice and is not an attempt to practice medicine or to provide specific medical advice, diagnosis, or treatment. This podcast does not create a physician-patient relationship and is not a substitute for professional medical advice, diagnosis, or treatment. Please do not rely on this podcast for emergency medical treatment. Remember that everyone is different, so make sure you consult your own healthcare professional before seeking any new treatment and before you alter, suspend, or initiate a new change in your routine. Welcome to The Starting Gate. We're your hosts, Dr. Kitty Dotson
and Dr. Sarah Sheets,
two internal medicine doctors who spent years practicing traditional primary care. Over time, we realized something was missing from modern healthcare. A real understanding of how everyday lifestyle choices impact overall health.
We'll help you cut through the noise of the countless health influencers and their conflicting opinions, because no matter who you follow, the basics of lifestyle medicine are at the heart of it all.
Welcome to The Starting Gate. We're your hosts, Dr. Kitty Dotson
and Dr. Sarah Sheets.
We're so glad you're back with us today. Hopefully you enjoyed last week's challenge trying to get in those 30 different plants. Sarah, how did it go for you?
I was close, but I didn't make it. I think I made it to 25, but it was close. I was still proud of that, but not quite there.
And 25 is good. And really, I think data-wise, even getting to 20 a week shows some major benefits for your gut microbiome and your health in general. So we're going to continue talking this week about some of our women's health issues, and we're really excited to delve into a topic that probably doesn't get as much attention as really it needs to, and that's PCOS.
We know many women out there either have recently been diagnosed or have this diagnosis already, or maybe struggling with infertility and are having to explore it. So we want to be able to provide some good education on PCOS today. So we called in an expert, and we have Dr. Elizabeth Elkinson, who is an OBGYN here in Lexington, and she is going to answer many questions for us and give her expertise. But to get started first, we would love to hear a little bit of background about you. How did you become an OBGYN? And how did you end up in your current practice?
Well, thank you, Sarah and Kitty. Thanks for having me on today. I developed an interest in OB-GYN in medical school at the University of Kentucky. When I was in medical school, I loved the combination of internal medicine and endocrinology and OBGYN versus the group that likes OBGYN and general surgery. So I always liked women's health, and I really debated which angle to take my residency training. So I ended up doing OBGYN, but I've always approached OBGYN from an aspect that the female reproductive organs are just part of a woman in general. And if you don't pay attention to the whole person, you really don't have as effective of therapies. And I think that polycystic ovarian syndrome is a great example of a problem that we see a lot of as OBGYNs, but that really requires a more general approach and considering the entire person, because it is such a problem that affects so many different aspects of a person's health. When I finished my residency training, or when I finished medical school, I did my residency training out in Los Angeles, and then I came back to Lexington. I was in a private practice doing general OBGYN, and when I would have patients that had complicated problems like polycystic ovarian syndrome, I realized that there was a real inadequate amount of time to both teach a patient what the problem was and then explain the multifactorial approach to management, including a lot of lifestyle modification that was difficult to achieve in these little short appointments. So over time and years, I decided to move my practice to a model that would allow me to have more time with patients. And so I do a concierge gynecology and women's health practice now called Bluegrass Gynecology and Wellness. And that practice really gives me the time to kind of focus on patients that have more complicated problems.
And I know we're talking about PCOS today, but can you just give our listeners a little bit of insight onto some of the other things that you help manage in your practice?
I take care of a lot of patients who are perimenopausal and menopausal. I have understanding of hormone management as a menopause certified practitioner, and really enjoy explaining the nuances of hormone therapy to my patients. I also provide gynecology care, imaging, surgery when indicated, and I also provide primary care services to my patients.
Sounds great.
I love it. I think it's I have such a good time. I just like the fact that I can get to know a person and to take a problem that maybe they've tried to address in other places and have gotten little snippets of care, but don't feel really satisfied with the general direction that they're going in with that problem.
Yeah, and I think sometimes talking about some of the problems that come up in the field of gynecology can be uncomfortable for someone too, and so they may not always express all the things that are going on. So having time to really build that relationship and have time to talk about it and is probably helpful.
And in particular, I think a problem like polycystic ovarian syndrome, where you have your fertility can be impacted, your weight, which is so sensitive, and the skin and hair changes that often are just glossed over as if it doesn't matter. But to patients, those problems are really impactful in their quality of life. And so I think it's really important to treat the whole person and treat the whole person respectfully, because as you all know, in a lifestyle practice, people have often been treated so disrespectfully. I mean, just having their weight described to them in a way that you wouldn't ever talk to someone that way. And so I like to look at PCOS as this opportunity when patients come in that we can really just say, like, let's take a deep breath. Like, this problem, if you already know you have it and you don't like where you are with the management, like, all right, let's just slow down a minute and get to the bottom of it, and then kind of proceed with all the different either lifestyle modifications or medical management that are required.
So for our listeners, if you've never known what PCOS is, if this whole topic is just new to you, can you give us a definition of what this condition is, just to get us started?
Polycystic ovarian syndrome is a complex metabolic syndrome rather than condition, syndrome, that's characterized by hyperandrogenism, ovulatory dysfunction, and the appearance of polycystic ovaries on ultrasound.
Okay, say that to us in non-medical terms now.
I know, and that's one of the things that is so difficult when a person is diagnosed with polycystic ovarian syndrome, is that the definition is a bunch of medical terminology. And so hyperandrogenism, androgens are a group of hormones that are in both men and women, but we often associate androgens with the male sex characteristics. So androgens, although they're in plenty in women, they are an incredibly important part of our hormones, but they are testosterone, they're androstenedione, DHEA, DHEAS. And so androgens are hormones that are typically produced in our ovaries, but they also can be produced in our adrenal glands. And so in polycystic ovarian syndrome, there are evidence of excess androgens resulting in skin changes that can be acne, hair loss, and hirsutism. So the hair pattern changes that are typically, and I'm putting quotes, quote unquote, male pattern hair changes, including terminal hair on the chin or neck, in the mid-chest, on the back, growing down the stomach, in areas that typically we associate with this male pattern change. Ovulatory dysfunction means that people are either having infrequent menstrual cycles, which is oligomenorrhea, or they're anovulatory, meaning they don't have menstrual cycles. And those have specific definitions, too, that your doctor would get into when you came in for diagnosis. The appearance of the ovaries is a specific criteria based on the number of follicles that you look at. And that characteristic requires an ultrasound. In the newer endocrine guidelines of polycystic ovarian syndrome that were released in 2023, you also can use an anti-Mullerian hormone level, which is another ovarian hormone.
So should anyone that has irregular cycles or anyone that ended up having an ultrasound or CT scan of their abdomen or pelvis for some reason that sees cysts, should anyone with either of those things just come asked to be evaluated? Do you need to worry about it?
I think that those are two really distinct questions. And I think the first question, if you have irregular cycles, so if your distance between period is more than 35 days regularly, or you have fewer than 9 menstrual cycles a year, that is the criteria for oligomenorrhea. And so if you couple that with skin changes of hyperandrogenism, like acne or hair loss or hair growth in places that you didn't have it, and that occurred usually in your late teens, early 20s, then yes, I think that you should seek evaluation for polycystic ovarian syndrome. Because at the end of the day, PCOS results in metabolic changes that are really important for your general health. And so even though who doesn't like to have fewer periods? I mean, like, why not? Some people come in there like, I love this pattern. I haven't had a period in 2 years. And I'm, in my mind, I'm like, oh my gosh. But they're like, they're thrilled with that pattern, And so even though it might seem very convenient to you not to have a period, it can be a marker of something that can profoundly impact other characteristics of your health. The question about ovarian cysts comes up all the time because I do have patients that come in after having an episode of pelvic pain where they go to the ER and they get diagnosed with an ovarian cyst as the source of their pain. And then they'll come in for an evaluation of an endocrine problem like polycystic ovarian syndrome, and they'll tell me about this cyst that they had on their ovary. And I think it is a real disservice that we named polycystic ovarian syndrome polycystic ovarian syndrome. I wish they had left out the word cyst because it's so confusing. And in fact, in the about 10 or 15 years ago, there was a conference where a bunch of endocrinologists said the name is wrong. We should rename polycystic ovarian syndrome. It's very confusing to people. But I guess no one was creative enough to come up with a new name, so they didn't rename it. But I always regret that they didn't because a lot of people do come in with that great question like, hey, I have this cyst. Is this polycystic ovarian syndrome? And in fact, I reassure them that a functional cyst or a follicular cyst that causes a lot of women to seek care in the ER for the severe pain, that's often the result of ovulation. And so for a person that may have polycystic ovarian syndrome, if they developed a cyst big enough to cause pain and go to the ER with, that was an ovulatory cycle. And so I always try to put a silver lining on that cloud and say, that was actually evidence of ovulation. And one of the troubles with polycystic ovarian syndrome is it results in anovulation or reduced ovulation.
And for those patients who have PCOS, is their cysts different? Do they look different on ultrasound? Because I know that's a question that I have been asked before. Or is it more so that it's just something that you find in general and it's not actually causing the problem?
Polycystic appearance to the ovaries is part of the definition of polycystic ovarian syndrome, and it's characterized by over 20 antral follicles or the volume of the ovary having a certain characteristic. And the follicles that are characteristic of polycystic ovarian syndrome are typically really small, not a giant cyst that's painful and stretches the ovarian capsule because it's bigger than the ovary, and so it causes pain. Instead, there are lots of small follicles, and those follicles over time increase the overall volume of the ovary. And it's really important, the characteristic and the look of that follicle really is part of the problem, because in each of these antral follicles, you have cells that surround the follicle that produce the androgens or the excess testosterone that really drives the characteristic skin changes that we see. And that excess androgen and that component of the follicle, those theca cells surrounding the follicle, that is the area of the ovary that is affected by excess insulin. And so then it drives the even further production of those androgens. And so when you have a bulky ovary, the other thing that's in excess is anti-Mullerian hormone. And so that anti-Mullerian hormone, and you remember we said that can be now used to characterize polycystic ovarian syndrome, that anti-Mullerian hormone also makes it more difficult for a follicle to ovulate. So the characteristic of these multiple small follicles with lots of theca cells that can produce excess androgens, and then ultimately the bulky ovary producing excess anti-Mullerian hormone, which makes it harder for the ovulatory event to occur, it all contributes to the picture of a person with PCOS.
And why does one woman have PCOS and the next does not?
Well, first of all, PCOS is a really common problem. And it's a syndrome because there is a cluster of individuals that have hyperandrogenism, oligo-ovulation or anovulation, and polycystic appearance to the ovaries. And the genetics of this problem are not fully understood. And so why would one woman have it and another doesn't is going to depend on what genes she's inherited from her family. And we know PCOS does have a genetic component because they have shown that there are familial groups that have PCOS. In twin studies, 70% of identical twins have PCOS versus fraternal twins that only 30% have PCOS. So there is a definite genetic component, but the genes involved, there's not one gene involved. It's multiple genes that can affect really different targets. Like some can be affecting the pituitary gland, some can affect the insulin receptors, some can affect the way follicles are produced. So all these different gene problems ultimately contribute to a similar picture in a person. And so for right now, we're calling all those people PCOS because they all have the same phenotype or appearance and result, but the genetic cause is very different. The other thing that's important is there is an environmental component to PCOS because even if you have the genes for PCOS, it is not a life sentence. It is a predisposition to some of these problems, and there are a lot of lifestyle factors that are really important in how your body expresses this complex multifactorial genetic problem.
And so if someone has one type of genetic abnormality and another woman with PCOS has a different type, would that affect maybe one of them is more predominant with acne, whereas another one has more trouble with weight?
Weight is interesting because, and that question is really complicated, but weight is interesting because weight is not a definition of PCOS. Excess weight is not a definition of PCOS. But women with PCOS are about 3 times more likely to have insulin resistance and obesity. And excess weight and insulin resistance leading to elevated insulin can negatively impact the hyperandrogenism, because insulin can act like a stimulation to those theca cells. And so then it increases the androgens. So the heavier a woman is, the more likely she is to have some of these negative skin changes, including acne and hair loss, because of the excess insulin.
Would that make you have, if your genetic change affected the pituitary, are you more likely to have one constellation of symptoms, whereas if it affects the ovary, you're more likely to have another constellation, or we maybe don't know that yet?
We don't know that yet. But I do think that is why there's so much variation in the response to treatment. So some women do really well with metformin. Like, there are medications that we traditionally use that help increase secretion of insulin. And some of those medications, in a percentage of women with PCOS, will result in ovulation. You know that you can stimulate ovulation with metformin alone in a small percentage of women with PCOS. And then in other women, it does nothing. And so you wonder, are those the women that maybe have a insulin receptor problem? And so you're addressing that with the metformin.
Along that line of insulin, because I find this part so interesting in general, even as a doctor and how we learned about things. We kind of learned about gynecology diseases together, and then we learned about metabolic diseases together, and linking them was not something we often did. I think medicine as a whole is being better about looking at people as a whole and realizing that nothing functions on its own and everything is connected. So in thinking about insulin and insulin sensitivity, could potentially you have the genetic propensity for PCOS, but let's say you have just been lucky enough to lead a very healthy lifestyle and you've never had trouble with your insulin levels being high, then resulting in insulin resistance. Could that keep you from developing PCOS?
I think that about 20% of women with PCOS don't have insulin resistance. And so you can still have you can still have the diagnosis of PCOS without insulin resistance. I think that lifestyle modification to control weight and increase physical activity can resolve PCOS. So I do think there is an important role in diet and exercise in the management of PCOS that I think is often skipped.
And before we dive, because that's what we talk about here, before we dive in that, just one question that I know may be in our listeners' minds, and just for you to clarify, at this time, do we have genetic tests to look for some of these markers for a patient to have drawn and to find out?
There are no specific genetics tests for PCOS. There are specific lab tests once you have been diagnosed with hyperandrogenism, oligomenorrhea or anovulation, and possibly the characteristics of polycystic morphology of your ovaries. There are specific lab tests that are recommended to exclude other causes that may look a lot like polycystic ovarian syndrome. And so although there is not at this time a genetics test for PCOS, there is a laboratory workup for polycystic ovarian syndrome that's important, because you do want to exclude causes that mimic PCOS that would need a different treatment. And then you can really focus the patient on the fact that there is management, there is hope. This isn't a problem that once you have it, you're destined to be anovulatory and infertile. And I feel like sometimes people feel that way. I have patients that come in and they feel like they really have lost hope in their ability to lose weight. They feel like, do weight loss techniques work for me? I have PCOS. I know that doesn't work for me. I'm going to be overweight. And I really try to get people to kind of regroup, step back. And the same strategies for weight loss, reduced calorie diets in all different formats and exercise in all different formats are also effective in people with PCOS.
So that was an excellent answer to that question. So let's dive in. What are those things that when a patient has received the diagnosis that we've just talked about, they've had the appropriate workup to exclude other things, and they're sitting in an appointment and they're wanting to know, what can I do to manage my PCOS through my lifestyle? What is that?
Well, when you look at the problems that are associated with PCOS, they're sort of lumped into categories: effects on fertility and menstruation, metabolic changes, skin and hair changes, and weight changes. And so when patients come in and they're ready and ask questions like that, I think looking at it as this may be an opportunity for several visits.
Agree, right?
It's
like,
hard.
How can you do that in a 20-minute visit?
You can't.
You can't.
You cannot.
You just can't do it.
So I like to prioritize. Like, some patients come in with the physical issues like acne and hair loss. Some people come in because they're 38 years old and they really want to have a baby. Some people come in for they're perimenopausal and they're now type 2 diabetic and have hypertension and cholesterol issues. And so I think it's really important to start with, where is the person in their life? What is their priority? And then kind of start addressing the lifestyle change for their priority.
So for someone that's, let's say, more concerned at this time with the skin and hair issues, is there specific recommendations you would give them from a lifestyle standpoint?
The skin and hair changes associated with PCOS are the consequence of hyperandrogenism. So when you have excess hair growth on your face, typically the management can be aesthetic treatments. If I have patients that are uninterested in hormonal management, then there are aesthetic treatments, but they're expensive and not covered by insurance.
And is that something like a hair laser?
Laser hair removal. And then there are medications that are targeted towards blocking the conversion of testosterone to dihydrotestosterone, which helps improve hirsutism and acne in general. But if you look at the guidelines for the management of PCOS, one of the reasons that hormonal management of PCOS is recommended is because it addresses the excess androgens. And I think patients don't always understand that, because a lot of people come in and they're like, my OBGYN just put this pack of pills in my hand and I don't want to take birth control pills. I'm not sexually active. And so I think it's really important to understand that when you're taking a hormonal contraceptive pill with estrogen and it's passing through your liver, that process results in the promotion of the formation of a protein that binds up excess testosterone. And so that birth control pill that helps regulate your menstrual cycles and polycystic ovarian syndrome is also having a secondary effect to improve the skin changes of polycystic ovarian syndrome. There are individuals that aren't a good candidate for birth control pills. Like, a person with PCOS also has increased rates of depression. And some people find that hormone pills in the past had really made their depression worse. And I find these people, they're kind of hard to manage, because you want to put them on something hormonal, but it's like you just don't. You can't. They've already tried it. And so those are individuals that I start looking at topical creams that also can block the aromatase in the skin that blocks the conversion of testosterone to dihydrotestosterone, using things like spironolactone. And then for hair loss associated with PCOS, that's typically androgenic alopecia. And the good news about androgenic alopecia is there's more treatment to that, although it is a lot of it is medical. But there are also some treatments with supplements like biotin and some of these other components that have shown some effect.
And with that being said, because a lot of times people may be interested in using medicine knowing that there's a chance that if they have a lifestyle aspect as well, they can improve it, that they may be able to stop it at a later time. Is that something that you see with that group of symptoms of the hair loss and the acne changes?
Yes. I think that especially with individuals who are interested in lifestyle changes and who are interested in ultimately embracing weight loss and increasing physical activity, those types of lifestyle modifications, if those result in about 5% weight loss, so if you lose 5% of your body mass and weight, people can have improvements in all kinds of parameters of PCOS. So you can see a reduction in androgens that can be measured in the lab. You can see improvement in insulin resistance by indirect measures of glucose monitoring. You can see increased regulation of the menstrual cycle by increased number of periods per year. And so I think when individuals start with one treatment, because that's where they're at, they need to do something to treat this acne, or they need to do something to treat this fact that they haven't had a period in 2 years or something. Ultimately, with lifestyle modification as an adjunct to medical treatment, there is really a plan to eventually be off medication.
I think that's important to know and be okay that you are using something as a bridge. Yeah, that's not wrong. Because I know some people hold that and feel some sense of that they shouldn't, knowing that it could be reversed. But it is okay to use these medicines to get you to your ultimate goal.
To the ultimate goal. And then ultimately, I think PCOS is something that you're going to have for your whole life. It's a multifactorial genetic problem. And so people have it starting in their, teens to early 20s, and it continues through perimenopause and into the metabolic changes influence risk for long-term health problems. And so I think embracing lifestyle changes that ultimately are going to reduce your risk of the long-term problems of PCOS, like reduce your risk of type 2 diabetes, reduce your risk of hypertension and cholesterol problems. I feel like that's the point of having a patient with PCOS meet with a registered dietitian. That's the point. It's not for this year's weight goal. It's for down the road improvement in your metabolic health.
Yeah. And we talked about all of those things in your risk of cardiovascular disease last month in our Heart Talk month, because really it's all those things combined, and all of those things have an additive effect that increase your risk of heart attack and stroke. So we're getting all the way from talking about menstrual cycle, and then you realize all these things have an effect on each other that can increase your risk of these chronic conditions like diabetes, high blood pressure, and high cholesterol, which ultimately what we're worried about that for is we don't want you to have a heart attack or stroke. So when you kind of put it all in perspective, it can feel a little overwhelming.
For a person, for an individual, I agree. I think that's why it's really important as a practitioner to sort of help tease out, like, what brought you in today? What was the reason that you sought care today? Was it because you are having trouble with weight? Are you having trouble with fertility? Or are you having trouble with skin changes? Like, where is your problem? Because this is a multifactorial syndrome that can affect so many different characteristics. You can get bogged down in it. And so I definitely think that having someone help you say, like, where do you want to start? Because you can start anywhere.
Yeah, it's just getting started. And like you said, it's a process, and hopefully you can make little steps over time and maybe not need, 3 years from now, you may not need the same treatment that you do right now for whatever is bothering you. So for someone that is kind of just initially taking hold of the fact that, let's say they have PCOS, or they're worried that they have it, and they want to start making some dietary changes, are there any specific diet changes that you recommend starting with, or more just, what works for you? Or you mentioned seeing a dietitian?
I think that that is a great question. And I actually looked at a meta-analysis of lifestyle modifications that impact PCOS. And one of the things I thought that was liberating about this meta-analysis is literally almost any diet that results in weight loss, whether it be, no matter what the type of diet, can improve the metabolic parameters and the hormonal parameters of PCOS. And so I think that's liberating. And that's also difficult because sometimes
all at the same time, yes.
What I want is someone to tell me what to do, not that I need to do it. And so I think that question, like, is there a specific type of diet that's better for PCOS? There are individuals that promote specific type of diet, like foods with lower glycemic index or lower carbohydrate content. And I think that kind of makes sense to me. And I think that it is not required, though. So I think importantly, if you're a person that can do Weight Watchers, but intermittent fasting seems like torture, like do Weight Watchers, like do whichever of the dietary changes. I also think, and I've heard you guys talk about this before, small changes can make a big difference. And so when people come in and they're carrying, and you should see this size beverage I have today, if you're carrying a 40-ounce Starbucks, there are places that we all can improve our diet. And it's just important to say, hey, a calorie restriction of some of the diets in this meta-analysis, they were reducing 500 calories a day. I mean, that's your Starbucks right there. So it's not like incredible changes that were impactful. And so I don't give one specific diet. And that's why I do like to work with a registered dietitian, because they have the time and the expertise to be like, if this type of diet makes you feel queasy or this type of thing really bothers you, you don't have access to these types of foods, like people coming in from towns that don't have, a Whole Foods or something, like you want to meet people where they are.
Do you know if insurance covers PCOS as a diagnosis to pay for seeing a dietitian?
The registered dietitian that I work with is credentialed with insurance. So we do use the diagnosis codes of PCOS and then whatever BMI the patient has, if they trend into the, different classes of obesity. We use those diagnosis codes to try to get people's insurance to cover that cost.
And we all know that that's hit or miss depending on an insurance.
Yeah, but definitely worth looking into if that's something that you...
Yeah, I definitely try, I like to try to utilize the person's insurance.
And we know that this link between insulin sensitivity and PCOS is something that diet can impact significantly. And we now have things called continuous glucose monitors that you can get more data on exactly what your glucose or blood sugar is another terminology that you'll hear is doing. And that also correlates with what's going on with your insulin. Luckily, we're getting more tools for patients that have PCOS that they can use to help see what different dietary changes can do and even know in real time the impact that they may be having. So I think it's really cool that you can use those, and now you don't even have to have a diagnosis to get them because you're able to just purchase them directly from the manufacturer.
I agree. I think that those could be helpful in patients with PCOS with insulin resistance, because I think also some of the symptoms that people with insulin resistance will experience are these low blood sugar episodes where they feel woozy or dizzy and they don't feel well. And I think it's really interesting to see how insulin resistance doesn't always mean you have high sugar. It also can be low sugar. And so I think that a continuous glucose monitor could be helpful in that regard.
You mentioned intermittent fasting, which came to my mind when we were thinking about this as something that could potentially be helpful in improving that insulin sensitivity. Is that something you have much experience with or seen people be successful with?
In using that specific diet to improve insulin sensitivity, I feel like the proponents of intermittent fasting will probably skewer me, but I think that in my experience, intermittent fasting in studies shows the same effects on weight loss over time that any diet does. And so I don't specifically propose that as a better diet, but if people naturally, their eating cycle naturally leans towards that, I think it can help. I've heard the arguments and the reasons why people feel like it improves insulin sensitivity, but I think diet with weight loss does that too, and no matter what the form of the diet is.
I know I've seen in my practice that intermittent fasting is something that it really just depends on the person, whether or not it's a successful strategy or you tolerate it well, et cetera. So I think that's it's not that it's the approach. It can be an approach, but it has to be the one that's right for you for it to have the success. Because some people feel miserable doing intermittent fasting, and we don't want you to feel miserable. The whole goal is to make you feel better.
You can't stick with something that makes you miserable. And so, and I think also that feeling of hunger for some people is really higher in people with PCOS, because when their insulin levels are higher, that also stimulates hunger cues for people. And so to take someone who has insulin resistance and then ask them to do something that innately is going to be a harder strategy for them is, I just think that you have to be more open-minded and embrace that there are a lot of different strategies out there that can improve lifestyle for individuals with PCOS.
Do you see for someone that has PCOS but is not overweight, do you see any specific dietary changes that help them, or do they even need to worry about trying to improve their diet?
I have seen in papers where anovulatory people who are not overweight still have improvement in ovulation with dietary change. So if you're a person who has a diet that's full of simple sugars and refined sugars and have an overall quote-unquote unhealthy diet, there is health benefit to improving diet. And so I think that they should.
Could you go into a little bit more detail about how exercise can impact someone with PCOS?
From my understanding, exercise improves insulin resistance. And so exercise as part of a life strategy for PCOS shows the same impact as diet on improved parameters of PCOS. So in that study I quoted, the meta-analysis, there were certain studies in that meta-analysis that just did increased exercise. And that showed improved lab parameters and improved rates of menstrual cycles. In the 2023 guidelines that came out recently, the recommendations for exercise for people with PCOS are really expanded. I mean, they recommend 250 minutes of moderate cardiovascular activity a week. They recommend, and so that's 50 minutes of exercise 5 days a week. And that doesn't have to be like running up a hill, but it can be things like activity, so increased activity. Then they recommend 2 episodes of weight training a week, and then they recommend 2 episodes of increased intensity cardiovascular activity. And so I think importantly, the significance of an increasingly active lifestyle on the long-term effects of PCOS are being recognized. And these new recommendations to me were, they caught my eye. Those were a lot of minutes. Was more. Mm-hmm. That's more than like the.
That's more than the recommendations for anyone else, right? Like an average recommendation that's escalated.
Yeah. And so I think that it's important to look at exercise as a component that these international experts on PCOS think are important to add. And so I think I'm going to try to embrace those changes in my patients too, and try to encourage people to be as active as they can be.
What about things like sleep or managing someone's stressed, do you see those impact their outcomes?
I think that there is an association of increased rates of obstructive sleep apnea in patients with PCOS. And I think that can greatly impact sleep. I think people who don't get enough sleep typically have higher cortisol levels, and that can impact the ability to lose weight. And so I think that sleep it's really important to see, is the PCOS causing a problem like obstructive sleep apnea that you need to address and treat in order to improve your patient's sleep? Or are they not sleeping enough, and that ultimately is impacting their ability to have sustained weight loss and improved health? And so I think sleep is critical in almost anything in your life. But I think it is definitely both PCOS causes obstructed sleep apnea, impacting quality of sleep, and then also sleep turns around and worsens the treatment of PCOS, makes it more difficult. PCOS is also associated with increase because there's a psychological component to PCOS. So when we look at PCOS, we know that people with PCOS have higher rates of stress and higher rates of depression and anxiety. And so I think that stress can really, if you have lifestyle modifications that you can embrace that improve stress, I think that you could impact your quality of life with PCOS. And so I look at things like meditation and yoga and things where you're doing lots of breathing and lots of, and try to conscientiously incorporate those into your day-to-day. I do recommend those types of behavioral modifications for patients that are having high stress.
Yeah, that's always one that I feel like is never addressed in medicine. We forget to talk about, like, how are we managing our stress? Because if we don't attack that, then honestly, the other lifestyle factors are hard to deal with.
Because a lot of people want to have their cortisol measured, and they want to know what it is. They're like, I'm sure it's through the roof. Like, I know it is. I'm so stressed out. And I'll measure it. I'm curious, I'm like, it may not be covered by insurance, but I'll measure it. And I think then I like to ask, like, how do we address physiologically high cortisol? Like, what's your strategy? What do you think is the strategy to address high cortisol? And, people want a supplement for it. They want something that you can take that reduces your cortisol. And I start to talk to them about the way we actually reduce cortisol is getting more sleep at night, reducing our stress levels. And so I think that behavioral changes that people can incorporate daily, like a meditation app where you're spending 5 to 10 minutes in the evening or in the morning, where you're really just conscientiously reducing stress is really important.
Yeah, and not trying to lean into some of those unhealthy behaviors to manage our stress, because that's what our environment usually tells us to do.
Yeah, scrolling social media and having a lot of alcohol probably won't improve those cortisol levels.
Yeah, or your insulin resistance. Or your insulin resistance, yeah.
For someone that does really dive in on these lifestyle modifications and they're really working hard on all of these things, is it possible to essentially make this diagnosis go away? Can you achieve remission in a sense?
I think that you could, through weight loss and exercise and improvement in insulin resistance, you could have improved ovulation. You could have an ability to reduce your risk of type 2 diabetes, improve your lipid profile, and improve your metabolic risks in life. But I think that diet and exercise alone aren't always adequate for everybody, because as a multifactorial problem that has different degrees of expression in individuals, some people may be able to embrace those changes enough to resolve the problems that they're experiencing. But a lot of people may still need medical management of anovulation or resulting in infertility, or their lipid panel is still indicative of higher risk with their family history, and they'll still need medications for that. And so I think that lifestyle is really important, but also finding solution for the specific issues that are specific to an individual that they feel are tolerable, that they can embrace, because everybody doesn't necessarily want the same treatments. And so, I mean, there are supplements, like medical supplements, that can improve the sensitivity to some of the hormones that improve ovulation. And so people will use some supplements if they're not interested in medications like combined oral contraceptive pills. So people will use things like inositol, chasteberry extract. Like there are supplements that can be used in addition to lifestyle modification that will appeal to some people. And then some people prefer to have the FDA approved, this is the ACOG recommendation, first line treatment. And so I think it's really important when you have a problem that is a chronic medical problem that you find someone that can talk to you and appeals to you in the management.
So you're speaking to someone out there that's listening that has PCOS that maybe hasn't gotten all this nuanced information from their gynecologist or other provider about this. Is there anything you would recommend them kind of going into to say to their gynecologist to let them know, like, should they just say, I really want to just be straightforward, I really want to focus on lifestyle, or I've got a lot going on in my life and this is not something I can really give my all to as far as lifestyle changes. I'd really rather think about the medication route, or I'd rather think about the supplement route. Should people just kind of go in and give that information to their provider? Is that helpful to you as the treater of this?
I think that's a great question. I think in a practice today, if you walk into your gynecologist at the time of your annual exam and they've got 10 minutes to talk to you about cancer screening, breast cancer screening, basic annual exam kind of questions, and then you bring into them like, hey, can you talk to me about lifestyle modifications for polycystic ovarian syndrome? Like, you diagnosed me 5 years ago and I've stopped taking my birth control. I'm cycling every, 3 months and my acne is bad and I feel like I'm losing some hair. I think understanding that in current medical practice, you may need to come back for a specific problem visit. And if it is a concern to you and you have specific worries, prioritizing that aspect of your health and scheduling for that specific problem, I think for a recommendation for like, how do I navigate today's medical system with this problem? That would be my advice, is to just realize that it may be the most important thing to you that day, but if you booked an annual appointment, that's not what the doctor thinks you're there for. And so that's sort of navigating healthcare 101, but this is a really complicated medical problem, and I think it needs its own visit. And so in the contemporary medical system, trying to overlap complicated problems in one problem visit at your OBGYN there's usually not enough time for that. So give your provider a chance to say, like, I'm coming in because I've got PCOS and I want to talk about it. And that way, at least that day, they're like, okay, we're going to talk about PCOS. To me, that would at least give them a chance to help you get what you need.
I think that's great advice. And for someone that's most concerned with infertility, are the lifestyle strategies the same for them, as we've already discussed? Or
Yeah, they are. And I think it just kind of depends on where you're at. If you are 25 years old and you've just decided to get pregnant and you know you have polycystic ovarian syndrome, I would really encourage embracing lifestyle changes, dietary changes, pursuing this 5% weight loss to try to maximize your body's ability to ovulate. And then if you're 38 and you have PCOS and you have the exact same problem, I would come in to the doctor's office and address it, because now you have polycystic ovarian syndrome and you have age. And so both of those impact fertility. And so I think that it's really important to have a realistic conversation, because the person who is 25 years old has more time on their side than the person who comes in with PCOS who's in their late 30s and just decided they wanted to start having kids. And so both of those individuals' lifestyle changes are going to be really important, but you would want to move faster in the individual that's older.
So don't wait to talk to your doctor.
No, not for fertility issues or questions. I never look at there's too young of a person to come in. I have conversations with 20-year-olds where they want me to reassure them about their fertility. And I know they have PCOS. And I think it's really important to explain, hey, this is what PCOS does to your ovulatory function. Like, you're not ovulating as often, so it doesn't mean that you're infertile, but you've got less chances per year to get pregnant, and it's not at an organized time in the monthly cycle. So it's more difficult to figure out when that's going to happen, and that can reduce fertility rates. And really try to educate people on when you're ready to conceive, that there are medications, lifestyle changes that we really want to embrace and to help you ovulate and move past that roadblock to fertility.
And on the other end of the spectrum, what about for perimenopause, when these patients hit that time in their life? Is there different pieces of advice that you then give them at that stage of life?
Well, I mean, hopefully with someone who is entering perimenopause, you really want to start paying attention to the cardiac changes, the metabolic changes that PCOS can impact. And so really paying attention to how you can optimize someone's health in terms of behavior, diet is really important because of those increased risk for the metabolic syndrome, hypertension, diabetes, and lipid problems. And so I really look at my patients with PCOS as they age, that those are really important. The other thing that is associated with PCOS with anovulation is over time, people have a higher risk of hyperplasia or uterine changes that can increase their risk for uterine cancer. And so when somebody is postmenopausal but had PCOS, I take the changes of postmenopausal bleeding. I have to factor that into my mind. And in my evaluation, that's a person that has a risk factor for endometrial cancer. So if you are a woman in menopause and you had PCOS and you're having some abnormal bleeding, which by definition after menopause is abnormal, you should come in for an evaluation. And that should be something that your doctor should take seriously and evaluate with ultrasound and biopsy if indicated.
That's a good reminder out there.
Here's another reminder, because I feel like I heard this misconception from patients very frequently. A pap smear does not assess for uterine cancer or ovarian cancer. It only assesses for cervical cancer. I don't know if you hear that a lot, but I would hear from patients, well, I don't need to worry about ovaries or uterus because I had a pap smear. And
important points of clarification. A pap smear is with HPV testing is designed to screen for cervical cancer. It does not screen for ovarian cancer, and it does not screen for uterine cancer. And so there is no screening test that we have at this time for either ovarian cancer or for uterine cancer. So for women in menopause who develop bleeding, that's a sign, that can be a sign of uterine cancer. And in fact, about 10% of women with postmenopausal bleeding can have either a precancer or cancer. And so that symptom alone warrants a trip to your either primary care or gynecologist to let someone know that that's happened, because it warrants an evaluation. And for ovarian cancer, there are some really interesting ideas in ovarian cancer risk reduction, but we don't have a screening test for that at this time.
So never ignore your symptoms. Always at least just go talk to your doctor about it to see if you need to do anything else.
I guess as we're kind of finishing up here, is there anything that we didn't touch on about PCOS that you would like for the listeners to know?
I feel like this was a pretty thorough conversation about PCOS. I think that it's such a multifactorial problem that not feeling overwhelmed and just realizing like anywhere you start's a start, wherever you feel like you're most bothered by the symptoms, that's a perfect place to start. Like start there, And so I think there's not like one strategy for every person. And every individual has preferences. And if you've been given something that you don't want to take, rather than look at it as like, this is the end of the road, I'm not going back, just go back and say, I really don't want to be on this type of medicine. What are my other options? Because there are other options for management and most medical problems. And so PCOS is similar to most medical problems or most medical conditions people have, in that there are lots of ways to take care of it. And if you don't like what you're on, rather than feel hopeless or nobody can help me, I would consider going back for a fresh perspective, and say, what else is available?
Yeah, I think that is great advice, and something that we always encourage here is really trying to have these conversations. And I loved your advice. Schedule those specific appointments where you can dedicate time to a discussion. It may help you tremendously. I know it's going to be able to provide that extra time that your doctor is going to need to do some clarification. And if you're not getting the assistance you need, find someone else that's going to be able to help you understand your personal risks, because this is individualized and it should be a priority. And take the time to really understand your own health.
Yeah, and one thing to be aware of, because as I was looking into some things on PCOS in preparation for our discussion, there's a lot of things on social media where it's acting like you just need to do this one thing, like hit exercise, like high intensity interval training, or you just need to fast. And I think that Dr. Elkinson did a really good job today explaining that that's not the case. And there's a lot of different ways that you can improve your symptoms. And so don't be fooled by seeing something online that looks like all you need to do is X, Y, and Z to fix your PCOS.
If it is a single product that they're like, this one supplement is all you need, and then you read about the supplement and it does 20 different things, I look at that as a red flag. I don't know about you, but I was like, anything that does 15 different things is not typically going to do anything much. So I agree with you. I think that women with PCOS, because there is a component of it's a chronic problem, it affects fertility, it affects mood, it affects people's sense of well-being. I think that it's easy for social media quote-unquote experts to really make people feel like they've got a solution, and people are a little, seeking a solution. And I feel like you've got to hopefully look past some of the social media nonsense.
Well, I think you've been very helpful today to clarify what seems like kind of a confusing topic, PCOS. So just to summarize, realize that PCOS is very common and it can present in a lot of different ways. And so it may be something that listening today, you may think, oh, I have some of those symptoms. Maybe you're struggling with weight and irregular periods, or maybe you've seen some hair coming up in a distribution that you haven't had in the past or haven't wanted. And so that might be a sign that you want to talk to your doctor about it. But we know that if it is something you're worried about, definitely speak to your doctor, because there are labs that need to be done so that they can exclude other things which could look a lot like PCOS. And then realize that this is a whole syndrome. It's not just one thing or one symptom, and it's something that can affect a lot of systems in your body, from your fertility and your menstrual cycle all the way to your insulin sensitivity and cholesterol, and even to your skin and hair. So each of those things are important to you, and be straightforward with your doctor about where you want to start on your journey and talk about how you want to approach it. We know that lifestyle change can help with all of those types of symptoms, and even just a 5% weight loss can result in improved insulin sensitivity and improved levels of those androgens, of those hormones that we want to bring down in PCOS. But do what works for you. There is no one right answer for how to do this. So find a diet that works for you. We know that you need to exercise, so figure out what works for you there too. When can you work it into your day? And that 250 minutes may seem overwhelming. So if you're at 0 minutes, let's aim for maybe 10 and then start building it up over time. So remember, you don't have to get all the way to 100% right away. Just start making changes and you will get there. And then also don't forget to manage your sleep and your stress, because we know that plays a big role as well. So we hope this was helpful to you. And if you know anyone in your life that maybe has PCOS or has been worried about that, please share this episode with them too.
And we hope you listen in next week, because we're going to continue our Women's Health Month. And hopefully you are enjoying all of this dedicated information, because we're really trying to hit topics that don't get a lot of press, and we want to be those educators for you. And if you enjoyed this show, be sure to share it. Follow us. If you have any other ideas for upcoming shows, please send us a text or email us at contact@thestartinggatepodcast.com.
We'll see you next week.